Hello and welcome to Healthbeat, a new program on television and digital platforms worldwide. This show is produced by the Bekisisa Centre for Health Journalism in South Africa. We ask the questions about health that people want to know the answers to. People affected by legislation, health policy and regulations. Whether it's COVID-19, HIV, sex education, gender-based violence or poverty-induced conditions, we strive to check the facts, verify the information and bring you a balanced view. I'm Malan, thanks for joining us. Coming up in the next half hour, some hard-hitting perspectives about health equality for people in Africa. We hear from a top infectious disease specialist who suggests it's time Africa got the return it deserves from participating in trials to test new medicines. We introduce you to a young mother completing her school education thanks to massive efforts from sex education experts. And we delve into the latest developments of South Africa's national health insurance scheme that the government is planning to introduce to make healthcare accessible to everyone. Up first, is Africa getting a fair deal from drug manufacturers who test their medicines on the continent's people? In July, experts from across the world gathered in Canada at the International AIDS Conference. An injection that can prevent people from contracting HIV was at the center of attention. The manufacturer VIF Healthcare conducted parts of its trial in Africa. Following huge public pressure, VIF Healthcare last week issued a voluntary license to the medicine's patent pool. The organization negotiates with drug companies for permission to produce cheaper, generic versions of medicines. But it will take years before such products are available, and only 3 manufacturers worldwide will be allowed to produce affordable cabotegravir injections. So what happens in the meantime? To get some answers, I spoke to the co-chair of the Africa Vaccine Delivery Alliance, Dr. Ayoade Alakija, who joined us on a video link from Abuja in Nigeria. Dr. Alakija, thanks very much for making the time to join us today. Let's go into the issue of VIF Healthcare. They've now issued a voluntary license and it will take years for generics to still be produced. And the company has said that it will also, in the meantime, make available their branded injection to 90 countries at a cheaper price. But they haven't told us at which price. And if we go by the history of pharmaceutical companies, we know they're not transparent about money. What now?
Also, whilst we welcome the fact that they have caved into pressure, because really that's what it is. It's a caving into pressure, which reminds us why what we do and what you, the media, do to help us put pressure on these inequities and the health injustice in this world is so important. So they've caved. I mean, so we welcome the fact that they've caved to pressure, but it's all still very blurry. As you've said, you know, they've said they will provide it at a price, but what is the price? How affordable is that price? They have given a list of 90 countries that they will make the patent and available to through MPP. So, I mean, it's a step in the right direction, but the basic intrinsic issues around the inequities and the fact that we have to almost beg, scream, shout for the very basics rights to basic healthcare and life that others in high-income countries enjoy, we still need to continue to interrogate.
Do you think African governments can do more to negotiate with pharmaceutical companies?
I absolutely do. And I think African governments, it's not just about negotiating with pharmaceutical companies. I think, and I've called for this before, I called for this when African governments, when the high-income countries and the UK and others shut out Africa, South Africa and others during when Omicron wave first started, that African governments themselves need to wake up. African governments need to understand that our lives are at stake. And it is not just about negotiating with pharmaceutical companies, but it is about using and utilizing our geopolitical power in such a way that we become reckoned with, because at the moment the world is not reckoning with us because we're not fully, you know, utilizing who we are. We're not standing up. We don't, I would say sort of almost colloquially that our leaders need to recognize who they are, how important they are in terms of the wider global polity of nations, as it were. You know, right now we have Russia on the doorstep of Africa. We have Macron, President Macron of France, also visiting African countries, because there's this competition for who Africa is going to lean towards. It needn't be a competition. Our leaders also need to themselves stand up and be able to be the statesmen that sadly most of them are. I don't see many women. We have one in Africa, you know, the statesmen, and let us speak, you know, let us speak prophetically into the distance, the stateswomen that they should be. We have a problem of leadership, which is why the world is taking us as people for granted and is making it look like a life in Abuja is worth less than a life in Alberta, Canada. That should not be the case. A life in Cape Town should be worth the same as a life in Connecticut.
If an African president came to you today and say, what should I tell the pharmaceutical companies? How should I do this to stand up against them? What advice would you give them?
It is not so much what I say, it is what I do. You know, and that is what I'm saying about our leadership. I think our leadership need to begin to put their foot down in those geopolitical spaces, be it at the UN or at the various assemblies that they attend, that they often go to as sort of, you know, they have a speech and they make a speech, but they need to start making demands. I would say, you know, Mr. President, I would advise that you tell these people who are refusing to purchase and refusing to support our own homegrown pharmaceutical industries that until they do that, we no longer want what you are giving to us. We will go looking ourselves. We will find our own procurement mechanisms, because if it is not meant to benefit us as a people, if you want to keep this dependency, this charity model, the charity model no longer works. It needs to be a partnership model. We need global multilateral partnerships, not global charities that are basically controlled by men, largely from the high-income countries of the world, who tell us who must live and who must die. It is wrong.
So just last week at the AIDS conference in Canada, many people from Africa couldn't attend because they could either not get a visa or they simply couldn't afford to travel there. How does that impact on who's got to have a say in how to tackle HIV?
I myself have been unable to attend that conference because of the prohibitive cost. I have friends who were denied boarding, having paid over $20,000 to get visas, to buy tickets, to go so that their voice could be heard. Winnie Binyima herself, the executive director of UNAIDS, who's from Uganda, an African woman, was almost denied boarding to attend a conference, which basically is her core business in Canada, because she is a Black woman. One day we will have a conversation about institutional racism in health. One day we will have the conversation about why we are still in a pandemic, because institutional racism meant that when a director general of the World Health Organization, who was a man from Ethiopia named Tedros, declared that the world had a problem, presidents of high-income countries refused to believe him. They denigrated him. They disrespected him. They disrespected his voice, as they are disrespecting us today, as they are disrespecting our voice. That is why they're not allowing us in the door. So what I am calling for is for people to stop hosting these conferences in these places. You cannot talk about us behind our backs. The majority of the burden of the disease is in our countries, and largely because you refuse to provide us access to drugs, refuse to provide us access to testing for HIV. So it is for COVID. So essentially, there is no point in having these conversations behind closed doors with people from high-income countries who will again decide for us what we must do in our own countries when they have no idea what it is to walk in our shoes.
This institutional racism that you're referring, of course, goes even a step further to the research world, that when researchers from the global north come to the global south and use the equal help of global south researchers to do their research, when it comes to publication, the global north people are almost always the main authors, and the global south researchers get less recognition. How do we change that?
We have to shake up this world. I mean, you are stirring me up, Mia, and I need to not be so upset. It's not about being upset, because then they will call one an angry Black woman. It is about recognizing that we cannot leave this world to our children. I'm the mother of a girl child who I want to not have to fight the fights that I have fought as a woman, that I don't want to have to walk into the spaces that I walk to and have to almost cower and keep my voice down just so that they will let me stay in the room, because they must not feel threatened by the power of Africa and the power of woman. So we're going into gender, we're going into institutional racism, but it is a power of money. It is a power of the dollar, because the power is in their hands. Money is power. So it is those institutions that have power who will say to the likes of me, Yodi, come, let me take your ideas down. What do you think about this over a phone call? They will walk away. They have 10 research assistants. They will write everything that I've said down and they will publish it at their own. It happens even to me, even today. People are still doing that because I don't have the time, because I don't have the resources. So that's why I say that money is power. We're dealing with power cuts. We're dealing with security issues. So we don't have the time and space to reimagine this world. But what we need to reimagine the world of global health. We need to reimagine the world of global development. We need to look at what equity looks like. We need to have the conversation about institutional racism that says that because my voice might be slightly different from yours, your voice has more value because you're a man, or because you're Caucasian, or because you come from the global north. And what I'm saying is, whilst multilateralism is great and it is what we need as a world, we have to reimagine it. We have to redesign it. We have to be involved from the ground up. They cannot just use our voices.
That was Dr. Ayoade Alakija, the co-chair of the Africa Vaccine Delivery Alliance. She spoke to us from Abuja in Nigeria. Stay with us. Up next is a story of how a change of attitude about sex education at school is giving young mothers a better future. But first, a look at how teen pregnancy figures have increased in South Africa over the past few years. We are continuing to have conversations about teenage pregnancy in South Africa. Research published in the South African Medical Journal shows that teen pregnancies have been increasing steadily over the past 5 years. These rising levels and school dropouts as a result is a concern across South Africa. But in some places the tide is turning, and it's all because of changing attitudes to sex education in school. Our journalist Yolanda Mzeki filed this report.
Thousands of teenagers fall pregnant every year in South Africa. Because of this, young mothers are often left with no choice but to leave school. Otlotleng Modikwe is 18. She's a matriculant at Matsukubiane Secondary School outside Rustenburg, South Africa. She's also the mother of a 4-year-old boy.
I was 13 years old. We didn't know more information about sex. Then it came out that the condom blasted and I became pregnant.
Teens say it's hard to get contraception from state clinics. Nurses judge them for having sex, and when they fall pregnant, they're cross-questioned.
They was just asking me, who is the father? I'm still young. Why was I having sex?
In Kanana village, a grade 8 class meets for their weekly life orientation class, which today includes a sex education lesson. These lessons start in grade 4, but teens say it's often not enough.
I think there are parts that are missing because they won't tell us about different kinds of preventions. They will just tell us about abstaining.
Tinyiko Rokubela works for Show Me Your Number, a non-government body working with schools to try fill in the gaps in sex education in the classroom. In a typical after-school session with high school girls, they'll talk about sexual health and societal pressures.
I'm their safe space. So when they come, they ask anything. Like the main thing that they ask about is all about contraceptions, like how to prevent pregnancy, how to be an independent young woman.
Comprehensive sexuality education was first introduced in the South African curriculum in the year 2000. In 2019, scripted lesson plans were introduced to help teachers cover these lessons. These classes include discussions on gender-based violence and power dynamics in relationships. Teachers aren't always comfortable talking to learners about sex. This can make learners feel awkward.
Sometimes I feel so. Even now, we are being taught all over men. Like, I won't be able to go and talk to say and tell him that say I'm in a current situation, so I don't know how should I find a solution. Please help me.
More information about sex in open talks, even in a classroom, is also changing mindsets.
Those who were pregnant last year, they gave birth and they managed to come back to school this year. So I can see like this program, it has an impact because we also preach this thing of like, even when you are pregnant or you have a child, doesn't mean it's the end of the world. You have to come back, like reach your goals.
Support from family goes a long way in empowering young girls to stay in school after having a child.
And an inspirational story, but some startling statistics in that report. Joining me now to discuss sex education and how resistance to it is being overcome is Thembi Mglati. She's a sex education facilitator at the Public Interest Law Centre, Section 27. Thembi, thanks very much for making the time to speak to us today. We've just seen an insert where a teenage girl managed to stay in school after she fell pregnant. But how many pregnant girls in South Africa really manage to do that, stay in school?
At Section 27, we'd like them to stay in school, but what's happening in their home, it doesn't happen. Most of them, they want to care for the child. There's not enough money for the children to be looked after, so they think staying at home is the best way. But we like the fact that this young girl stayed in school. That's what we're striving for at Section 27.
We've clearly seen from the figures that we saw earlier that teenagers are having sex.
Yes.
It's clear that that's happening. But parents often deny that because they think it's not great to do that. So what advice have you got for parents about their teenagers? Should they accept? What if they have a moral problem with it?
No parents wants to believe that my teenage child is having sex. So, but then we have to come to the reality that teenagers are having sex, and we sort of have the power to speak to them and drive them to the right route. I think that parents, they need to understand consent as well, speak to the children about consent, and also the children are having sex, but also the child must know that if they are consenting to sex, they're consenting to everything that comes with sex, pregnancy, they might contract HIV. So those parents, I wish that they will find a way to communicate with their teenage girls and show them the right way. If they don't, that's when they resort to their peers, and that's not the route that we would like the girls to go.
44 new posts have been approved for technical staff for South Africa's National Health Insurance Scheme, or the NHI as it's more commonly known. All of the staff will be based in Tshwane at the National Health Department's head office. But before we unpack what will happen with the NHI in the coming weeks, let's hear what people think of the scheme. Our reporter, Mohali Malloy, took to the streets of Johannesburg to find out if people think a public health insurance system like the NHI would work.
If others have medical aid, others don't have, others get better preference. And if we have, all of us will be treated maybe equally.
It's not going to work if it's going to be free for both, but for the poor, it should be much more affordable. So at least they can get a decent healthcare.
Expensive and unfair.
Pathetic, useless.
It's a bit tricky because currently people are not working. They cannot afford to pay for medication. But if we do not pay, we're not going to get a proper help. So I think we should not pay too much for it. It should be affordable for people.
So that's the view of people around Johannesburg about the NHI. To unpack the viability of the scheme and where South Africa is at with it, I'm joined by Nicholas Crisp, the Deputy Director General in the National Health Department, responsible for the implementation of the NHI. Dr. Crisp, thanks very much for making the time to talk to us today. It looks like the pace of implementation for the NHI is picking up. The Treasury has approved 44 new posts for the scheme. What will those people do?
Yeah, thanks very much, Mia, and it's nice to talk to you.
So indeed, we are putting the foundations in place for the administrative capabilities. If one looks at the NHI bill, there's a lot of work that needs to be done, a lot of preparatory work. And although it's a very long road, we need people to start drafting operating procedures. We need people to start drafting regulations that can go into the public space for consultation after the bill becomes law. And we need to start preparing the digital systems that are able to carry the work that needs to be done in the various areas of the NHI fund.
You've mentioned that these people will be technical people. What does technical be? What's the difference between that and administrative people?
So administrative people are people who look after human resources, finance, supply chain management, and so forth, whereas technical people are economists, public health medicine specialists, actuaries, lawyers, and people who will be doing the technical work, the drafting work, as opposed to looking after us and making sure that we are fed and able to drive around to do our work.
When will you start to advertise for these positions, and are there any more such positions that you're planning for, in addition to the 44?
So there's a business plan that was presented to the minister some time back, to the former minister some time back, that lays out the rollout over the next 5 years. But that is just to give us a picture of where we are going. And that, you can imagine, a very big running organization will need several hundred employees. Some of those functions already exist, and others of those functions will be completely new. But in the initial instance now, we have the approval from the Minister of Public Service and Administration to establish a transitional capability that will prepare for the entity. And we have authority from Treasury to use some of the money that had been set aside for preparing the National Health Insurance nucleus to spend on new conditions of employment. So we will commence with these 44 positions. We will inherit somewhere between 80 and 100 people and a couple of vacant posts from within the Department of Health who do functions that are described in the National Health Insurance Bill. And then once we have those processes well underway, we will then make a new submission to the Minister of Public Service and to Treasury to look at the next phase. But one doesn't want to run ahead of oneself. We need, over the next couple of weeks, we are hoping that the procurement process for the advertisements and the finalization of the advertisements are ready to go. And once that's in the public space, people will apply. We will do the necessary shortlisting, interviews, and the other processes that are required in the public service to recruit suitable incumbents to those 44 positions.
Timeline-wise, from what you're saying, it sounds like you are planning to appoint these people before the end of this year.
I'm not expecting that we will be making appointments before December, and it's highly unlikely that there will be people ready to commence duty before the start of the new calendar year. So hopefully we will have some of these 44 posts filled with incumbents to start work in the new year, while others will probably only join us February, March, and even into the new financial year.
Dr. Chris, just for clarity, there's an NHI bill that still needs to be approved by Parliament, but we're already seeing new positions becoming available. How does this process work? Do we not first need the bill so that we have an act for the NHI to first be approved and then we advertise positions? Why are you able to go ahead with this at this stage?
There's been a lot of criticism that we have not informed people what are the benefits. I can't inform people what the benefits are because there isn't a bill and there aren't people to design those benefits. We can't even do the benefit structure, never mind the definitions of the benefits, so it's a catch-22. So what do you do and what don't you do? We need a digital system, whether it's an NHI digital system or whether it's an integrated platform for us to deliver health services in the country on the current format. So what is happening is that those positions in the 44 that are potentially vulnerable to specific NHI functions are going to be on contract positions, and those that are inevitable, whether there's an NHI or not, can be on permanent positions. And that is the condition of the funding from National Treasury.
So what would, for instance, happen if Parliament doesn't approve the bill, or if there's lots of court cases that prevent the bill from going through for a very long period? What will happen to these people who are appointed?
Well, as I said, there are some of these functions which need to happen irrespective. So with the digital system, where more than about half of the 44 posts are in that digital space, that needs to go ahead irrespective of what happens with an NHI bill. If one is now not needing to design benefits anymore because they're not going to be benefits, then those people are qualified to do other things for the remainder of their appointment period, and we'll see what unfolds going forward.
That's our program for today. Remember, you can catch more content on health-related matters in South Africa on our website. The address is on your screen right now. You can also follow us on Twitter, Instagram, Facebook and LinkedIn on the handles on your screen. Until our next program, stay safe and keep a healthy perspective.